Hello, everyone. My name is Caitlin Bafis-Lasky, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm pleased to welcome you all to our educational webinar today, hosted by Lymphoma Canada at our national conference on follicular lymphoma. We appreciate those of you able to join us live today to learn more about the disease-specific biology of follicular lymphoma. We will examine the current Canadian treatment options available, and we'll also highlight treatments coming to Canada and the research and results behind these new therapies and clinical trials. Now, before I go ahead and introduce today's speaker, I would like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or microphone. If you do have a question, please save it for the non-Hodgkin lymphoma Q&A session, which will occur following this breakout presentation. You can then ask your questions live to the presenters. I would now like to go ahead and introduce and welcome our speaker, Dr. Ibrahim Othamn. Dr. Othamn is a clinical hematologist at Saskatchewan Cancer Agency and an assistant professor at the University of Saskatchewan. He established the General Hematology Program in Regina in 2017. His research interests include lymphoid and myeloid malignancy, plasma cell disorder, in addition to medical education. He is an active member in research and education committees in Saskatchewan and the primary investigator for clinical trials at the Saskatchewan Cancer Agency. We thank you very much for joining us today and developing this presentation to speak on this lymphoma subtype. I would now like to turn over the presentation to you. Thank you very much.
Thank you, Caitlin, for this nice introduction, and thank you, Lymphoma Canada, for organizing this such valuable meeting and conference. Hello, everyone. Today, I will present some information about follicular lymphoma. This is my disclosure slide. And today, the presentation will be about the role of B lymphocytes in our immune system. We will talk about how we diagnose and stage patient with follicular lymphoma. We will navigate through some options available for upfront and relapse setting with patient with follicular lymphoma. So this is our immune system. It's consistent with the bone marrow and other lymphoid or immunological glands that located in our body. This is the way I used to explain the hematopoietic growth in our bone marrow. So we are a human being. We usually born as a tiny creature, and by time we grow in size. This scenario is opposite in hematopoietic cells. The cells usually born as a big cells like blast, and by time it decreases in size. So when I see big cells, that's mean it's tend to be immature. When I see small cells, that's mean it's more mature and more wise. So in the bone marrow, where this is the school of our hematopoietic cells, we have two big classes. We have the lymphoid classes, usually produce lymphocytes, so it has lymphoblast now. And we have a myeloid classes, which produce myelocytes and different mature cells. Myeloid class, the student graduated after the high school and turned to be red blood cells, white blood cells, and platelet, and they travel through our circulation to start their work. While lymphoid, they are very ambitious, so they don't say enough with education. After finishing high school, they would like to get more education in the university. And university for lymphoid tissue, for lymphocytes are lymphoid tissues, which mainly lymph nodes. In the lymph node, they get their education, they go classes, and then they will graduate it as mature cells and ready to function. Lymphoid tissue, or the universe, usually located in our body in certain spots, usually close the major blood vessels, where we call them lymph nodes. Just to let you know, the lymphoid cells are not only B lymphocytes. We have many other cells. We have B lymphocyte, as we talk about, and this is the cell that's responsible for fighting infection. We have T lymphocytes as well, and it goes to a different university, which is the thymus, and it's mainly attack virus infected cells and tumor cells as well. And we have a natural killers, which is like a Rambo of our cells when they attack the virus infected cells and tumor cells as well. The students, which is a B lymphocytes, finished high school. Then these lymphocytes go to university, and the lymph nodes, they sit in classes, and these classes usually looks like follicles. So they sit together. So when we do a cut section on the lymph node, we can see a small cells because they are mature, and we can see them sitting in follicles. And in these classes, they get learned how to attack viruses. So basically, for an example, if a normal human receive influenza or flu shots, the lymphoid organ bring this small antigenic part of the flu or the influenza and start to teach B lymphocytes. Look at that. This is called influenza. This is called influenza. So next time when you see this antigen, get ready to attack. Then after graduation, they give them suits and they give them a mark on their hats called CD20. So they wear a hat called CD20, and this is important in the future when we talk about that in the treatment. And they give them guns and missiles. And these missiles called immunoglobulin. And the missiles usually, the factory start to produce missiles specific for specific antigen. For an example, influenza has a different missiles. Tuberculosis has different missiles. Any infection, and it's not only infection, it's anything could be antigenic. Like even when pollens we smell, this considered to be antigenic. So in our body, we have a lot of missiles, and they are marked by specific antigen and specific target. Because in the future, if the B lymphocytes get exposed to the same antigen again, they start to produce the specific missiles. So it needs a lot to create a specific site that can attack viruses. So this is really very complicated process. And this is where usually the process where the lymphoma start if there is any abnormalities in processing these antigens. Anyway, so the B lymphocytes enter the lymphoid tissue, and it is ready now to attack any antigen or any target. So what is lymphoma? Lymphoma basically those group or a group of B cells decided to behave odd, and they don't follow the order of the body, and they grow with uncontrolled manner, and they start to increase in size, and they refuse to retire and die. So there is the sequence is the number of cells will increase in numbers, and then it start to block the flow to the lymphoid tissue, and then start to spread even outside the lymph node. And as we mentioned before, these are many universities and they are connected together. So it can spread from one lymphocyte, from one lymph node to another lymph node. So lymphoma can start in any part of lymphatic system. Lymphatic system, it's not only lymph node, by the way, it's the bone is including a lymphatic system and spleen as well. And it can spread and grow in many parts of the body. The bad thing about that lymphoma can do a compression over vital organ, as we will see later on. Hematopathologists, clinical clinicians, and gene specialists, and they decided to divide lymphoma into two big categories: the non-Hodgkin lymphoma and Hodgkin lymphoma. And under non-Hodgkin lymphoma, we can divide according to behavior to aggressive, which has B cell lymphoma and T cell lymphoma, and indolent or non-aggressive, which follicular lymphoma located at this part, and it has a B cells or T cells. And again, every time they put their information in a big book, WHO, World Health Organization, and the most recent one published many types of lymphoma. So lymphoma, it's not only one disease, it's many types, could be an aggressive, could be an indolent, but everyone have a different presentation and a different treatment. What can cause lymphoma? Interesting, more than 90% of lymphoma has no reason can explain this disease. There is some theories about radiation exposure, immune deficiency status. We see that with patient who has an HIV infection, or patient underwent organ transplant, kidney transplant, and start to develop lymphoma, part of the side effect of their immunosuppressant. Congenital immune deficiency as well can increase the risk of lymphoma. And interesting that there are some viruses can cause lymphoma, like hepatitis C and HIV and H. pylori as well. As we discussed before, we can divide the non-Hodgkin lymphoma in two big categories: the indolent lymphoma and the aggressive lymphoma. The difference that aggressive lymphoma are usually rapidly growing, often have symptoms because they grow quickly, and the patients start to complain from compression symptoms and B symptoms that we will talk about in the future. Fatal in months if there is no treatment is available, and it potentially cure with a standard therapy. While indolent lymphoma, where the follicular lymphoma fit, it's slowly growing, often asymptomatic, and usually long natural history. Sometimes the patient even doesn't need a treatment for the disease, and it is incurable with standard therapy. And this is the idea of not giving medication upfront if the patient has no symptoms. How much percentage follicular lymphoma form from the non-Hodgkin lymphoma in general? It's about 25% of non-Hodgkin lymphoma. It's considered to be a big portion, especially if you compare the follicular lymphoma with other low-grade lymphoma. Follicular lymphoma considered to be one of the biggest, or one of the highest number in the rate of in the subtypes. The name of follicular lymphoma came from the shape of the lymph nodes biopsy when we take it from a patient with a non-Hodgkin lymphoma. Usually we see small cells, and those cells located in follicles. And as I mentioned, because they are small, they are wise, they are good, they are mature. They are not diffuse or large, like diffuse large B-cell lymphoma, which is more aggressive. This kind of lymphoma can cause few symptoms in early stage if there is any compression symptoms, usually affect middle age and older age. Response to treatment is good, but unfortunately it can cure as well. It can return as well, and can transform to aggressive lymphoma. Patient with follicular lymphoma sometimes present with different symptoms. Sometimes the patient has no symptoms at all and just only lymph node enlargement. We see that a lot. Axillary lymph node incidentally discovered, cervical lymph nodes accidentally discovered. Sometimes we see patient with sickness, and this sickness we call it B symptoms. B symptoms where the tumor is a little bit active, and the turnover of the cells are very quick, leads to fever, usually low-grade fever, night sweat, sometimes it's drenching sweat. The patient need to change the sheet every morning, or need to change their clothes every morning. Weight loss, and when we talk about weight loss here, we talk about significant weight loss, more than 10% of the current weight in less than 6 months. Or if the patient lost about 10 kilograms in 6 months without intention. The patient usually come, I lost a lot of weight, I found my clothes is a little bit wide now and I have to change the size. Anorexia, which means the loss of appetite, the patient doesn't have any interest anymore to eat the food that he or she would like to eat. And pruritus, which is itching on the skin as well. Local manifestation, it depends where the lymphoma is. If the patient has lymphoma on his neck, and then this leads to a change in the voice sometimes. Big spleen can make the patient feel uncomfortable, especially with driving. Feel discomfort, pain on the left side. And any tissue can be infiltrated, like we sometimes see a skin infiltration by follicular lymphoma, but sometimes it's very rare. If I have a patient come to my clinic and have these kind of complaint, then this is the way that we reach the diagnosis. First, we do physical examination to assess the cardiac and respiratory and abdominal as well. We do a lymph node examination to see if there is any specific lymph nodes. We pick one we can reach by a biopsy. If we couldn't find a good one, we can even do a CAT scan all over the body to see if there is any good accessible lymph nodes. Once we have lymph nodes in our mind, and then we send the patient to do a biopsy. We would like to have an excisional biopsy for sure. Incisional biopsy is okay. Fine needle aspiration, it's still question mark, but if we have an access to core biopsy or excisional biopsy, this will be way better to help our pathologists to reach the diagnosis early without any confusion. We do another blood work, like complete blood count and differential. We do an LDH, which is important for staging, and sometimes it gives us a prognostic marker in non-Hodgkin lymphoma. We do sometimes bone marrow biopsy if at certain point in follicular lymphoma, we know that 70% of follicular lymphoma have bone marrow involvement or come with a stage 4, but sometimes we do it for staging. Imaging for follicular lymphoma, we do a routine imaging. As we mentioned, we do a CAT scan, and the CAT scan give us information about staging and can give us some information about if there is any compression by lymph node over vital organ. Ultrasound over the kidney can give us impression if the patient has mild back pain and with renal impairment. That can give us impression that there is a compression of the lymph node over the ureter. PET scan, we are not very excited to do PET scan upfront for patient with follicular lymphoma. CAT scan, sometimes it's more, we do more CAT scans. The reason we don't use to do a PET scan upfront, because we know that follicular lymphoma is low-grade tumor, and PET scan is more accurate in high aggressive tumors like Hodgkin lymphoma or like diffuse large B-cell lymphoma. But we now do it as a routine if we are suspecting transformation, or in the term of relapse as well, we do a PET scan. Our pathologist will take a lymph node biopsy, and she will take a look under the microscope to confirm or to see the diagnosis. As I mentioned before, we see small cells under the microscope. We under the microscope, they sometimes grade the pathology as grade 1, grade 2, grade 3, and under the grade 3 there is grade 3A and grade 3B. This grading based on the number of big cells there and the size as well. We know that grade 1, grade 2, grade 3A, we treat almost all of them as the same. Grade B, like mean 3B, we treat as diffuse large B-cell lymphoma. So grading is important in the morphology. We do immune histochemistry. We stain the slides, and as I mentioned, follicular lymphoma usually wearing the hat of CD20, and sometimes they wear another hat with CD10. So CD20 is the marker for B lymphocytes, and CD10, when we see CD10, we think about follicular lymphoma. Cytogenetics sometimes confirm the diagnosis, and gene profile expression as well. Now, few comments about CAT scan and PET scan. As we mentioned, CAT scan, we use CAT scan for staging for follicular lymphoma. You can see here there is some compression by, or some lymph node enlargement. We sometimes see compression of lymphoid tissue over vital organs. It's important for staging as well. PET scan is another way for catching more aggressive disease. If you look at the picture on the left here, this patient has lymphoma involved neck and the mediastinum. And then after treatment, the patient almost cured. The heart, this is normal to find uptake on the heart and the brain and the urinary bladder. And the idea of the PET scan is, we know that the cancer cells are very active and they consume more sugar. For this reason, we send them a sugar on top of radiolabel material, and based on the amount of the uptake and the site of the uptake, we can catch the disease and we can know where exactly the disease is and how aggressiveness or how is rapidly dividing cells present there. Again, as I mentioned, PET scan is not a standard in follicular lymphoma upfront, but we use it sometimes for the transformation and for relapse. I have few patients after completing the treatment, they keep asking about doing a frequent CAT scan. So I put this slide to give you some information here. So this compare the X-rays and PET scan and CT scan in the term of the amount of exposure. If the patient has an X-ray, it's expose him to 0.1 MSV. While if the patient had PET scan, that's mean it exposed to 12 MSV, which equal 120 chest X-ray. While the CAT scan itself, it's really a huge exposure of radiation. And if you want to know what exactly that means, for an example, when I travel from Saskatchewan to Toronto in 3.5-hour flight, it's almost equal to exposure of 1 X-ray. So, so we have to be very cautious when we do a follow-up for our patient with imaging, and it's better to follow the guidelines and to use the right safe imaging. So I have a patient, lymphoma, diagnosed by lymph nodes, clinically assessed, and the CAT scan was done, and now it's time for staging. Staging of non-Hodgkin lymphoma based on the numbers of lymph nodes above and below the diaphragm. Diaphragm is an organ in our body, muscular organ. It's split the abdominal organ or the organ inside our belly with the organ in our chest. So if there is only one lymph node in one side of this diaphragm, either above or below, we consider this is stage 1. If we have two groups of lymph nodes only in one side, so this is a stage 2. While stage 3, that's mean there are lymph node enlargement, pathological lymph node enlargement in both sides of the diaphragm. Stage 4 means that the patient has more lymphoid more like infiltration or invasion of other organs rather than lymphoid tissue, like bone or skin or any other vital tissue. And then after that, we can mark the patient as a stage 3A, for an example, or stage 2A or stage 2B based on presence of B symptoms. And as we mentioned, B symptoms including night sweat, night fever, significant loss of weight, and significant loss of appetite. And then we can add the bulk disease, which means the size of the lymph nodes is more than 10 centimeters on imaging to the staging. So I can say that the patient has, excuse me, stage 3B bulky disease. Why this staging is important? Because sometimes we depend on the staging on the prognosis. This is a prognostic criteria called FLIPI, International Prognostic Index, and it has an age, stage, and hemoglobin level, serum LDH, and number of nodal involvement, and then they can score the prognosis as good prognosis, moderate prognosis, or poor prognosis. Just to let you know, this staging system was put in the time prior to Rituximab treatment. So with Rituximab treatment, I think this prognostic and number has been changed. So now we made the diagnosis of our patient with follicular lymphoma, and it's time to choose treatment. Treatment of follicular lymphoma, as I mentioned, it's an incurable disease. So if I give a patient chemotherapy, it's not curable. Sometimes the patient develops side effect of the chemotherapy itself. So if the patient doesn't have symptoms and the disease is not bulky and the patient doesn't have a B symptoms, and I found that blood work is good, there is no compression over any organs, blood work showed normal CBC, platelet, and white blood count, that's mean most probably the bone marrow is not affected, I do observation. We called it watch and wait. If the stage is only limited, so small stage like stage 1 or stage 2A, we can give radiation therapy. If the patient has an advanced stage and need a treatment, the patient has B symptoms, or there is a compression by the lymphoid tissue over the vital organ, then we can give chemotherapy or immune therapy, as well as we will talk about in the future. Watch and wait, we choose usually this option if the patient doesn't have any indication for treatment, and we found that its overall survival by studies showed that the patient usually, it's not a big difference between patient who receive a chemotherapy or patient has been watched by his medical oncologist or hematologist. During watch and wait, we know the patient sometimes they are anxious, so we ask them to ask any question to us, to report any change in their health, to take care of themselves, especially mentally, and be healthy and be active, to learn more about lymphoma by reading, by joining good societies like Lymphoma Canada. We talk about, we ask the patient to talk about certain concerns. Again, we want the patient, we are ready for supporting the patient for any concern or to answer any question. When we can think about starting treatment, if the patient during watch and wait, or the patient at the presentation, he start to have symptoms attributed to lymphoma, like compression, as I mentioned, by lymphoid tissue, a big bulky lymph node, distortion of the like compression over the cervical area or the neck. The patient has really disfigurement, big spleen. The patient is not able to even do their daily activity. Then we can think about treatment. And we have many criteria has been published. And in Canada, we used to follow these guidelines based on the tumor size and based on B symptoms, if there is any present life-threatening situation, or the patient has really very bad B symptoms. Option of treatment of follicular lymphoma upfront, we can use either chemotherapy to kill most of the cells. We can use radiation therapy, and as we mentioned, we can use it for single lymph node or early stage, like stage 1 or stage 2. Immune therapy targeting the lymphoma cells, or transplant, and usually we give that in the time of relapse, not upfront. Chemotherapy, the idea of the chemotherapy, it kills the rapidly dividing cells, which is tumor cells. And unfortunately, we have 3 other systems could be affected because they have rapidly dividing cells. Our hair follicle, and our bone marrow cells, which is blood cells, and our mucosa as well, like mucosal tract. This is why the patient, when they receive an extensive or heavy chemotherapy, there is some instance of alopecia. They can lose hair, but the hair will come back again. Sometimes they complain from mucositis. Sometimes the blood drop, like hemoglobin and platelet up to the patient sometimes need blood or platelet transfusion. Monoclonal antibodies is, I consider this is really a unique medication that came to be cell lymphoma or B-cell malignancy as well. Basically, these monoclonal antibody, they, as I told you, the B lymphocytes produce missiles, and these missiles attack the bugs or the bad viruses or bacteria. Here we create another missiles, and we are creating them to attack the B hat on the lymphoid cells. As we mentioned, all B lymphocytes were the CD20 marker, and these monoclonal antibody are targeting the CD20 on top of the cells, on top of the malignant cells as well, and on the top of, unfortunately, the normal B lymphocytes. But the good thing about them, the side effect of those monoclonal antibody is less toxic than the chemotherapy. And we found even in follicular lymphoma, when we add a monoclonal antibody, especially Rituximab on this study, to a regular regimen that patient used to use in the past, actually it's improved the survival. So for this reason, we added to most of the lymphoma protocol now. For follicular lymphoma, if the patient start to need a treatment, this is one of the most recent option and a good option for the patient, bendamustine rituximab, combination of chemotherapy and monoclonal antibody. We give bendamustine over 2 days, and we give rituximab on day 1, and we repeat this treatment every 4 weeks for 6 cycles. There is some side effect of bendamustine. It can cause some rash as well. After finishing the 6th treatment, that means 6 months of treatment, we put the patient on rituximab every 3 months for 2 years. Another option for treatment, which is SHOP, in addition to monoclonal antibody, which is rituximab as well, it's giving every 3 weeks, and again for 6 cycles. The idea of giving rituximab maintenance was very clear in this study. We found that giving rituximab maintenance for 2 years help to maintain progression-free survival, but it's not. It doesn't have any impact of overall survival. So this is why some centers in Canada used to use this regimen, and I think in most Canadian centers as well used to use a maintenance rituximab. There is another treatment came recently, and it called the R square, and R means, the first R is Revlimid, which is another alternative name of lenalidomide, and rituximab as well as a chemotherapy. Lenalidomide is one of the group called the IMiDs, which I consider this is a cousin of one of the medication used to be used long time ago for hyperemesis or for pregnant lady with frequent vomiting, called thalidomide. Unfortunately, thalidomide causes a lot of teratogenicity. So now thalidomide and lenalidomide came to cancer ward, especially with myeloma, and lenalidomide have some rules in lymphoma as well. So if the patient has to receive lenalidomide, it's important to make sure that they will avoid pregnancy, either even men or women, just to protect from any teratogenicity. With this regimen, we add lenalidomide to rituximab, and it was compared by a regular regimen, which is R-CHOP or bendamustine rituximab. And interesting, it didn't change a lot. I mean, the same cure rate, the same progression-free survival, but it adds some toxicity as well. So this regimen is not really very popular in follicular lymphoma. So these are the management strategy with chemotherapy and immune therapy with the upfront follicular lymphoma. When we talk about early stage follicular lymphoma, like stage 1 or stage 2, a radiation therapy is a good option. The good thing about lymphocytes, they are very sensitive to radiation therapy. This is why we sometimes even need low doses of radiation in comparison to other solid tumor. The patient comes to the radiotherapy department, and they do some assessment, and then they mark exactly where the radiation therapy will be targeted. And then the patient comes every day for almost 4 weeks, from Monday to Friday, to receive treatment. Usually they are very localized beam of radiation. Its side effect mainly will be skin and tissue beneath it. So if the lymphoma is in the mediastinum, it can affect the heart. If the lymphoma is just in a different site, like in the abdomen and pelvis, the toxicity basically based on the which organ is underneath or under the beam of radiation. I consider this is really a good and safe treatment, especially for early stages. Side effect of any treatment, especially chemo and immunotherapy, could be hair loss, alopecia, as we mentioned, and once the patient finishes the chemotherapy, the hair will come back again. Mouth sore as well, nausea and vomiting. We give a good anti-nausea medication. Tiredness and fatigue, we know that this is some side effect of chemotherapy. Fever, if the patient has low white blood count, and this should be addressed very clear to the oncologist, especially even after hour, the patient has to contact the oncologist on call and to express the feeling of fever, and the patient feels unwell. Sometimes the blood count is very low and the patient could develop significant complication and infection. Low blood count up to platelet and blood transfusion. Infusion-related reaction, this is mainly for Rituximab. As I mentioned, Rituximab is a non-human prepared monoclonal antibody. So sometimes our body responds in a different way to these kind of external immunoglobulin or external antibodies. So sometimes patients develop fever or chills or itching like an allergy. This is not a contraindication to stop the treatment. Actually, we can slow down the treatment. We can give anti-allergic medication and continue the treatment. The good thing about Rituximab now, it's available on subcutaneous form. So the first cycle, the patient tried as IV infusion, and if it is tolerated well, then we can move to subcutaneous, which is more convenient because rather than IV infusion in few hours, now subcutaneous in few minutes. Other possible side effects, heart dysfunction. If the patient receives some kind of medication, anthracycline, it can cause heart toxicity. This is sometimes we need to order few investigation and echocardiography before some protocols of chemotherapy. Peripheral neuropathy, this is one of the side effects of chemotherapy as well. Chemo brain, and this is a very common word in the cancer therapy, but it's not common manifestation, by the way. Sometimes patients feel difficulties with memory or thinking. By time, this could be improved. And some of these chemotherapy as well can affect fertility, so it's better to get consult from fertility program and talk to your hematologist or medical oncologist before proceeding for treatment if there is any plan in the future for getting children. Other possible side effect, social, including the patient should stay at home, and usually we give a sick leave because we understand that the patient will have a hard time to deal with cancer and chemotherapy as well. And immunization, we know that sometimes we have to postpone immunization, and the good example is COVID-19 immunization. We don't recommend to have the COVID-19 immunization right away at the same time of a monoclonal antibody. Otherwise, the body will not respond to this immunization. The patient finished treatment and achieved cure. We did staging after the treatment. We did a CAT scan, and the good thing, the patient is on remission. We keep following the patient every 3 months for almost 2 years to make sure that there is no element of relapse. And the family physician as well, usually they do follow up annually. They can do thyroid function if the patient get exposure for radiation therapy in his cervical area or neck area. Echocardiography as well if the patient get exposure for radiation therapy. Now, what happened if, unfortunately, the patient had the disease come back again? So it's very important to know that early relapse carry a higher risk of the disease. So if the patient spent quite 2 years free from the disease, this is considered to be a good sign. But if the disease come back earlier than 2 years, we consider this is a high risk disease and usually need an aggressive treatment, and the prognosis is not the best. One of the line of treatment of relapse or follicular lymphoma is stem cell transplant, autologous stem cell transplant. And the idea of the autologous transplant, as I explained to the patient, is if you have a backyard at home and you are implanting a very good nice fruit there, and the weeds comes from time to time, the best way to kill these weeds is to give them weedicidal, which is a chemotherapy that we give at the first time. Now, if the weeds come back again, then you need to clean all the field. But if you clean all the field by giving a new soil, you will lose your own fruits. And so it's better to collect this some seeds from these fruits and to save them, and then to give a very potent good weedicidal to kill every single weeds and the good cells as well. This is exactly the same thing happened in autologous transplant for lymphoid and malignancy. We know that if we give a heavy chemotherapy for this patient, the bone marrow will not be able to regenerate again. So we give a chemotherapy, and then once the disease is in remission, we ask the patient to donate from his own self, his stem cells, the seeds, and we collect them in nitrogen tanks to keep them, to save them. And then later on, we give an extensive chemotherapy, heavy chemotherapy and radiotherapy. Once we clear the soil, we give back the cells to grow up. And our hematopoietic cells, they are really incredible cells, and they grow up very, very quick, and they replicate the number very, very high efficient, in very high efficient way. So this is the idea of stem cell transplant, autologous stem cell transplant. And we found that when the patient undergo transplant, autologous transplant, usually the response rate is good, and the duration of response as well is good. Allogeneic transplant is a different story and a different rationale. So in allogeneic, basically we bring a donor lymphocytes to the patient's body to ask them to attack the bad cells. But we want to make sure that these donor cells will not attack extensively the normal healthy tissue on the patient. And why I'm saying extensively, because we know that at some point we need this. We need the graft versus lymphoma effect. We bring those lymphocytes, we put them on the body of the patient, and these lymphocytes or these immune cells, oh, where we are, this is a foreign body, let's attack. And then they will start to attack the lymphoma, and they will start to attack the healthy cells, and it can cause graft versus host disease. And this is why we sometimes need to give immune suppression to give some balance. It's really a tough procedure, but the idea is really very good, because we can kill the cells and we have to pay a little bit from expenses to do that. But in follicular lymphoma, we found, in spite that the patient is cured for a good amount of time, but if we compare the allogeneic transplant with autologous transplant, we found that autologous transplant is really better in the term of toxicity, because it's allogeneic transplant is really a very toxic procedure and maneuver. So we still tend to keep that allogeneic transplant in very, very unique situation and very rare situation. The other option of treatment of patient who relapse after receiving the first line of treatment is to introduce another monoclonal antibody. And this study compared adding obinutuzumab to bendamustine as a line of treatment, while on the other group they have only bendamustine. This study was done at the time where the bendamustine rituximab was not available as a first line. So most of those patients received R-CHOP treatment or RCVB treatment. The results are really very significant. We found that obinutuzumab has a good progression-free survival. That means the patient will live a good life without the disease, and overall survival. That means the patient even will maintain their life expectancy without significant toxicity or significant other comorbidity. So this considered to be a good option for patients who resist mainly rituximab treatment, to give them obinutuzumab. Another treatment for relapse called the PI3 kinase. We are targeting them. So if you look at this cartoon here, this is B lymphocytes or follicular lymphoma cells or B lymphocytes cell membrane, where we have some receptors. Those receptors take the stimulus and start to send signals to the nucleus and asking the nucleus to start to grow up and replicate and start to resist dying. We found if we attack those receptors, we can even inhibit this maturity and this formation, the growing of follicular lymphoma. So scientists invent targeting that can attack those kind of receptors. We have different kind of receptors. We have PI3 kinase alpha group, PI3 beta, PI3 gamma, and PI3 delta. And they start to invent targeting for each group of these cell receptors. So if you look here, we have idelalisib and we have copanlisib and we have duvelisib as well. Both of them targeting a different receptor, and all of them has a different side effect and toxicity as well. So based on which receptor they are targeting. The first one and the last one could be taken by oral medication, while copanlisib is intravenous treatment. And if I show you how the response with the idelalisib with the with non-Hodgkin lymphoma, follicular lymphoma, this is a very good curve, and this is, we call it a waterfall slide, where this is every column express a patient, and a patient usually responded very well, as you can see here, when they respond then more than 50%. Another option, we have EZH2, which is gene are expressed on normal cells to help normal growth. But in lymphoma cells, we found that some of them of follicular lymphoma have mutant in that gene, leads to that these cells resist to be dying. So we found a good targeting called tazemetostat, and this is affecting, or this is targeting EZH2 on follicular lymphoma cells, even if it is expressed or it's not expressed. I will talk in the coming few slides about CAR T cells, and the idea of CAR T cells, that we are bringing T lymphocytes from the patient and prepare them, and by the way, we make them a very good soldiers, and they then introduce them back to the human body, and then they will start to attack the lymphoma cells. We have many, but the commonest one is axatilimab, and this one has really a good response rate. We found that overall response rate is about 90%, and curability rate is almost 70%. So this is a good option for a patient who already received few line of treatment without good response, and we found really a good result here, and even 2-year survival considered to be good with this medication. Promising data also available here in Canada with a Transcend trial for lisocabtagene as well, which another CAR T specific or CAR T treatment for follicular lymphoma, especially for relapse and refractory. So to summarize, in relapse and refractory patient, there are many other factors can play an important role, like in age, other comorbidities, and as patient factor, there are other disease factor, like where the disease is and the stage of the disease, the size of the lymph node, if there is any transformation or not, duration of response of the previous treatment as well. Specific therapy option, prior therapy can target us or can guide us where to go with next treatment. The option for management for relapse and follicular lymphoma, either watch and wait. We can give the same prior therapy after if the patient respond well and spend a good 2 years without disease. Radiation if localized disease, chemotherapy and anti-CD20 as well as we mentioned, autologous transplant, targeting therapy as we mentioned, mutation profile, we can give anti-EZH2 mutation and clinical trial as well. By this slide, I end my presentation and thank you very much.
Thank you very, very much, Dr. Othamn, for your excellent presentation on follicular lymphoma. We really appreciate your really great overview of the lymphoma subtype, detailing some of the treatment options for patients in both the frontline and relapse refractory settings, and also highlighting some of the newer treatment options that are becoming available for Canadians. It's really interesting to see, especially related to CAR T therapy and what that holds in store for follicular lymphoma patients. I would now like to take a moment to direct our audience to please attend the breakout session on non-Hodgkin lymphoma to have your questions answered live by a panelist of hematologists and medical oncologists. Thank you once again, and we hope to see you there. Bye.